Hi, my name's Jennifer and I'm an MSc Physiotherapy student at St Mary's University in Twickenham. Working towards my next placement, I will be going on to my first respiratory experience as a physio student. And so I thought I'd take this opportunity to pick the brains of a fellow student that previously worked as a technician in respiratory physio and has also done a placement there, so she's got a wealth of knowledge that she can pass on to me. The following is just a few questions that I really wanted to ask Brooke and her interpretation of what to expect and how to best prepare for a respiratory placement. Hi Brooke, it's great to have you on the podcast. Thank you so much for taking the time out to help me with this tool and to really get to know what to expect before the placement. To start, if you could just tell me a little bit about your past and what you've worked in, the experience that you've had up until now. So how long did you work within RESP and how long did it take you to become confident and familiar with the environment and treatments that are obviously associated with RESP, like your Yanker suction, that can be a little bit more intimidating?
I worked through. Basically, that's all that I knew. So obviously we had a lot of patients with quite high respiratory needs. So I learned a lot very quickly. And of course, as a tech, my job wasn't to do respiratory physio, but I spent a lot of time supporting the qualified physios in giving respiratory treatment. So just being there for that support. And then did a 6-week respiratory ward-based and ITU-based placement, which is actually amazing experience and allowed me to do a lot of the things that I had seen but not been able to do. Actually, it's really quite interesting because I think you can never be too kind of confident or familiar in respiratory, where obviously in a lot of our treatment scenarios, patients can be quite unwell and sometimes quite unstable. So it's always really a really good point, I think, is to always just be kind of prepared and thinking on your feet for kind of a good case scenario from what might happen when you treat, but also what else could happen. So that's really important. I found that repetition of basic ward-based respiratory techniques was really useful for me to become kind of more familiar of the environment and the treatment. So your ACBTs, your NP suction, your oral Yanker suction, just keep doing those with educator and supervisor and just really familiarising picking a technique of treatment for the problem. So I found that once I could identify the issue, so is it increased work of breathing, is it sputum retention, then you get your toolbox and you look at the least invasive way that would work for that patient, considering, all the normal things that you would, their contraindications and their any contraindications in their past medical history. So yeah, I think have your toolbox, identify which things in the toolbox work for your main issues. So like I said, sputum retention, increased work of breathing, whatever it might be. And then always start as least invasive as you can. But yeah, interestingly as well about ITU in the ward is a lot of people are scared of ITU, but actually there's so many people around you in ITU and the patients have one-to-one nursing that I actually found it the complete opposite way round. I found the ward sometimes a little bit more of a scary place than ITU. But yeah.
That's so insightful, thank you. And I think it's really important to take away from that is that you find those 3 key areas of your sputum clearance, your work of breathing, and then you develop your flow of what you're then going to do, what would be best for this patient. And again, I think you're right. I think that comes with experience and just exposing yourself to that environment. So thank you. My next question is, what conditions did you see most frequently and would recommend studying prior to the placement? So what am I most likely to see, or what would you say is most important to, really understand before going on to that ward environment?
So I would recommend looking at your COPD and your management of COPD. It's very common in my experience from working in the acute hospital. Bronchiectasis as well is another one that we see, not so much as COPD, but again, we do see it. So just having to think about what are the common things for those 2 patients. So with your bronchiectasis patients, they retain sputum, which is really, really dangerous because they're usually very productive. So making sure that they still are as productive, if not more, with an infection than they usually are. COPD, they're usually hyperinflated. They usually got quite a high work of breathing. So just having a think again straight away, like if you already know that there are common issues with those conditions, like you've got your toolbox there and ready to go. And then obviously with our growing elderly population in the hospitals, the CAPs and the HAPs and the pneumonias from various places, aspiration pneumonias as well, which quite often, obviously, as you can imagine, would require your kind of more invasive suctioning methods for patients that do aspirate a lot. But as I say, as long as you can identify the problem relative to the condition, so, you know, if someone's got high work of breathing, they might have COPD, they might have an aspiration pneumonia, they might have bronchiectasis, etc. Actually, is the treatment going to be massively different? Not always. So just having your toolbox and then considering things about, you know, there's certain things for certain conditions that are contraindicated. So just think about that. But yeah, they would be the big three for me. Asthma's always one that people say, but I didn't have too much. Actually, a lot of physiotherapy, kind of chest physiotherapy treatment is not that useful for asthma, but just have an awareness of that, because, you know, when you're referred an asthma patient on the ward, you can think about what your response might be if you don't think it's appropriate that they have any chest physio.
Amazing. I shall definitely look into those. I think even just hearing you talking about it, I can see the depth of your knowledge compared to mine, and like you can reel off the things. So with your bronchiectasis, this happens, and then this happens, and then this happens, which is how you know where they're compensating. And I think that comes from a real depth of understanding, which I think I should work on before that placement. My next question is, have you got any tips on prioritising a caseload with the RESP team? Obviously, I know that this is commonly an interview question as well, and I think it's just a good idea to go in with a strong sense of where you should be when, considering if you've got a variety of patients, such as mobility patients, discharge patients, acute chest patients, and then you're trying to show that you're capable and you've got the capacity as a student to take that on. If you've got any hints or tips on that.
So, prioritization is obviously key when it comes to respiratory patients. And quite often, actually, in the Band 5 interviews, from what I've again been told, they will give a prioritization question to us, and, you know, say prioritize these patients. And there's always like two different kind of respiratory presentations in there, and I think people see like chest indications and they'll put them both at the top, but actually it's not always the way. So for example, if you've got, I don't know, an artificial airway, so a tracheostomy patient on 60 litres of oxygen and retaining secretions, obviously that's going to be quite a high priority for chest physiotherapy. But then you might have, say, a COPD patient on room air, self-ventilating on room air, and mobilising independently on the ward. And you might not necessarily put that person as high. So it's just thinking about who is, you know, the sickest or the most medically unstable, and who needs what treatment, and prioritising them. So obviously most places work with like a P1, P2, P3 system. Most chest checks, or all respiratory physio is a P1. But for me, prioritization just came with exposure and again, repetition. So just, you know, every single morning I would screen the ward, I would identify patients that needed chest physio, and this is on my placement. And I would then prioritise how I was going to go around and see them based on, exactly their stability, how medically unwell are they, what oxygen requirement have they got, what are their problems, has there been any other chest physio. So just like doing that, and then asking my educator to have a look, and then if he changed the order, you know, just getting feedback as to why. But it really is just about exposure and practice, in my opinion. In-depth screening with like good time management is really key. So looking out for the key things: what support is the patient on, what type of airway do they have, what are the other MDT notes saying, are the nurses suctioning, what do the doctors want, are they on nebs, things like that can really help you with your treatment. And then just determining the urgency of the treatment. But I would always, personally, a good tip from me was I always would liaise with the ward or the nurse sister, the sister in charge, nurse in charge, just to ensure that my priority was correct and like matched her kind of sickest patients list as well. Because sometimes she might say, oh, actually, no, the nurses are suctioning that patient and he's actually really stable. So maybe he wouldn't be the priority. Just things like that. So communication is key when it comes to prioritization, I would say.
100%. I completely get what you're saying there, that even though it is a respiratory physio treatment, it's not always a priority, because a lot of the time, especially following COVID, our priority is also to get people out of the hospital where possible. So it's good to hear you re-emphasising that, despite going into like an acute medical environment where, you know, chest seems like the be-all and end-all. So going on to my fourth question, did you ever get imposter syndrome managing respiratory patients as a physio, as a student, or as when you were a tech? Did you have to justify your presence to patients and family? I feel like, as someone that's not been in that environment before, going in as a physiotherapist where we are stereotypically at the side of a football field or just doing MSK and fixing someone's shoulder, giving out massages, I find it hard to, justify why it is our role to be going in and doing these quite invasive medical treatments. But I think that just shows my naivety going into this placement. So if you've got any guidance on that, I would really appreciate it.
Yeah, so not so much as a tech, because obviously there's a big solid line between what we do as a tech and what we do qualified when it comes to respiratory. So I would only literally ever assist. It would usually be that they need a suction and they need a double to get out into the chair. So that's why I was there, but I just had a lot of kind of observational exposure to it. As a student, I was doing most treatment alone, eventually with like distant supervision. Kind of got stuck in there quite quickly and just started with some of the techniques. I didn't really get too much kind of imposter syndrome or any kind of didn't really have to justify myself to patients. Obviously, you're always introduced as a student. They might be a little bit apprehensive, but it's not common from my experience. It's not commonly due to the student label. It's just probably some of the invasive treatments that we sometimes are talking to the patients about. I think that can be quite worrying, obviously, which is totally understandable. I think, the key is just the explanation, obviously getting the consent and listening to kind of what the patient wants, because, sometimes what we know that a good deep suction is going to clear, but actually, do they want that repeatedly every day? It's just having that balance. Obviously, there can be some difficult challenges and conversations, and sometimes capacity can be involved, like treating in best interest. But I think it's just about taking each patient as they come, listening to what they have to say as you would anywhere, because the patient comes first always. So but for me, just reassurance and like basic explanations were really useful with my patients. And I actually got some feedback sometimes from patients a couple of times that just said, like, it's actually really nice that someone spent the time to like break down exactly what treatment you're giving and why, and giving options. I think sometimes it can be, everybody's under so much pressure and strain. It's just getting their treat and get out. But actually, for these patients, it's really reassuring to know, okay, you are sticking a tube in my nose, but this is why. And actually, it can be really helpful to kind of to let them treat you.
I think that's lovely, and I think it's great that you always bring it back to that patient-centred care, especially when it's so invasive and so, critical condition sort of treatments. I think that's really nice. And that's something that I'm going to try and take with me into my placement. I've got one final question and then I shall let you go. So what is your top piece of advice for someone going into a respiratory placement with, minimal experience like myself? So I've always done MSK sort of things. So any advice is great advice.
I think my top piece of advice for a respiratory placement would be not to panic. Really easily said, not so easily done, but there's usually something that you can do. But also remember your clinical reasoning, and that leads me on to saying sometimes we can't always treat as we might like. So I think, the clinical reasoning for me is the best bit of advice. Why are you doing that? What is the problem, and how are you suspecting that treatment will influence that problem? And just having that in your head before you do it, speaking that through with your educator after you've done it. As long as you've got that sound clinical reasoning, and understanding why you're doing what you're doing, then you're going to be fine. I always just think, why am I doing this? What's going to come next? What are the possible outcomes, and what might I do depending on which outcome I get from my treatment? I always, as I said, I would just choose my treatment, explain it back to my educator and why I chose it. And if in doubt, don't be afraid to ask something. So if you're not sure why you're doing something or you don't know what technique, just ask, as in with any placement. Don't kind of, just give it a go and not really sure what you're doing or why. Just have a really clear, just say, not really sure how to do this, or not really sure why I'm doing it, can you explain? Because you'll feel more confident if you know why you're doing something. But yeah, it can be a very fast changing picture within kind of one chest treatment session. So just like communicating throughout that and then asking for help when you feel out of depth. So obviously as a student, you most of the time have your educator with you, but even in other situations, like that communication is key to both patient, but also like to other people in the room. So I would always say to the nurse in that bay, like, I'm going to be doing some respiratory physio now with this patient. Like, everyone's got an awareness of what's going on. So if you do need that little bit of extra support, it's not kind of, oh, what are you doing? It's clear. Everybody knows what's going on, including the patient. But yeah, don't panic. You'll be absolutely fine.
That's great advice, thank you. Thank you so much for taking the time to make this podcast with me. I think it's really highlighted where I need to focus and just to remain calm going into this next placement. And hopefully we can catch up at the end of the placements to see how we've gotten on. And then I'll also be helping Brooke film a podcast over for her Mahara page as she goes on to take part in an MSK placement, which is where I've previously gained experience as well. So you can always check that out too.